Okay, great. Well, while folks trickle in, I think I'm going to go ahead and get started and just give a quick overview of who we are at CA Bridge and what we do. So again, welcome to our California Bridge Virtual Regional Collaborative. We're so happy to see you all here. We're coming to the end of the year, and we're happy to announce that this is actually our last virtual collaborative or regional collaborative event of the year. So thank you so much for showing up. Thank you so much for being here and for being part of the conversation. We have a lot of great things for you today, and I'm really excited. So I'm really happy to see everyone who's wanting to collaborate and make a positive impact for those living with opioid use disorder. My next slide. So these meetings, if this is your first time here at the Regional Collaborative, welcome to the movement. These meetings are opportunities for us to come together across the region. So this is a statewide event, but we will also get into breakout rooms for people from each of your regions. And so we'll have 5 different regions today here represented, and you'll have an opportunity to talk about, local needs and strategies as well. And so I do want to say that we are building, that rapid access network, that rapid MET network, and you are integral to our success. Like everyone here is a part of it. And so we're really excited to continue making low barrier MAT available in every community in California. I want to introduce myself as your host. I'm the one where my name is plastered, and if you received any of the emails about the virtual collaborative, I'm that person. I am the project manager, so I do support the team in, making some of these events happen, and also focusing on expanding our rapid MAT network for addiction care. So that's just a little bit about me. So excited again to see you here, and thank you for having me. And if you are new to CA Bridge, we are part of the Bridge Center at Public Health Institute, and we do receive support from the California Department of Healthcare Services. And so now that most of us are in the room, I don't think we all had a chance. So let's do it. If you can feel free to unmute yourself too, just say hi, use the chat too, share your name, organization, city, county in the chat. So I'm already unmuted, but feel free to unmute and just say good morning to everyone. And I will be reading for as well from the chat. So I see Rumita, Shayna, Genevieve, Asma, Marilyn, Uma, Crystal, Ashley, good morning. And for more people, Chaya, thank you, good morning. Hi, Casey. Let's take some time to know who's in the room. Let's put your name in the chat. Feel free to unmute too. Hi, Renee. Joe from Anaheim. So we have a lot of people here representing from different places. I see Palmdale, I see Redding, Anaheim, Tahoe Forest Hospital, Sacramento. Hi, Taylor. Hi, Katie. Pomona. Thank you so much for coming. Oh, amazing. I love it. I love all the engagement. It makes me know that you're here. And I see you all also on camera. And again, if you are able to, please have your cameras on. I'd love to see your faces as well. So thank you so much. We're going to go ahead and get started with the rest of our agenda. We have great things for you today. As I mentioned, we're going to start with what I already just did, an introduction to California Bridge. And then we have 2 guest speakers, Brenda Grealish and Jenny Bayardo, to talk about the Commission for Behavioral Health and also the BHSA integrated plans. Then we'll go straight into our breakout sessions. We have a really fun activity for you. And after that, Dr. Herring wasn't able to join us today, so I will be going to a session on rapid MAT expansion. We have a navigator story here with our Seabridge Connect navigator, Katie Quijada, and then announcements, and that will be our full hour and 30 minutes. And so a little bit about, and learning objectives. For those of you who are CHWs, peer support specialists, substance use counselors, CEUs will be provided by the end of today's session. So make sure that you stay for the entirety of today's event. Your learning objectives for today are to discuss opportunities to engage with local and state partners for behavioral health transformation. Number 2, identify and evaluate community needs and resources for your region and gain insight into the services offered. And number 3, demonstrate the significance of collaboration and networking for patient care. And so, again, if you are new to us, I do want to share California Bridge's goal, and it is to make 24/7 rapid access to substance use navigation and addiction treatment across California. And so we have 279 hospitals across California, and we started with 8 in 2018. And so large-scale implementation is really unique to California, and we want to see this vision expand across California. And that really is our goal. And our model is three parts. So low barrier treatment means treatment is rapidly available 24/7, right? And it's a medication first model. And we want to maximize engagement in treatment. And number two is connection to care and community. And so this is really important, is that it's connection to outpatient care. How do we support an individual's long-term recovery outside of the ED? It continues, it requires more than just the ED. And the third part is a culture of harm reduction and destigmatized care to encourage engagement in treatment. And so that is who we are today. And we're happy to be bringing, and if you've been to these events before, we want to elevate voices who are doing this work. And so excited to have you in the room. And I want to actually get into our next session, the Commission for Behavioral Health and BHSA Integrated Plans, and introduce our two plenary speakers in the morning. So Brenda Grealish is the Executive Director of the California Commission for Behavioral Health. And she leads statewide policy efforts to improve behavioral health outcomes. She brings over 25 years of experience in state government with expertise in behavioral health, Medi-Cal, and the criminal justice system. And I will also introduce Jenny Bayardo, Executive Officer, California Behavioral Health Planning Council. And she has 19 years of experience across state service, higher education, and nonprofit organizations. She leads a 40-member majority consumer and family advisory council that evaluates California's public behavioral health system, and her work focuses on advancing policy and advocacy for individuals with serious mental illness and co-occurring conditions. And so I would like to introduce both of them. And Brenda, Jenny, feel free to just let me know when there's next slide.
Awesome, thank you. And actually, I was thinking Jenny might start first, or would you guys be okay
Yeah,
with that? And then
absolutely.
Planning Council actually started before CBH did, so I thought
They
maybe
did.
just in the order of history. Thank you.
Thank you. Thanks, Brenda. So I'll kind of just for some of you who don't know who we are, I will do a just kind of a brief who the council is, and then talk a little bit about the integrated plans, which is a space where you should be able to influence what's happening in your communities in terms of the BHSA fund. So the council, like in my intro, is a 40-member advisory body. Our council members are appointed by the Department of Healthcare Services. There are 32 appointed positions, and the other 8 are state department representatives. While our members are appointed by DHCS, they are volunteers who are not employed by the department, making the council independent of the department and the administration. We are required to exist as a condition of the state receiving SAMHSA mental health block grant funds. We also have some state mandates that include review and evaluation of the public behavioral health system. And you see our mission and vision on there, which is the first content slide. Um, uh, where we envision a behavioral health system that makes it possible for individuals to lead full and purposeful lives. And we do this by reviewing, evaluating, and advocating for an accessible and effective behavioral health system. And then the slide where you see the codes, this is just for your information. Here you can see the council's responsibilities laid out in the Behavioral Health Services Act, which is what we're talking about today. And they include oversight of behavioral health board performance outcome data, consulting with DHCS on county reporting requirements. And there's a provision for the council to request reports and data from the counties on BHSA. And the commission also has responsibilities in BHSA, which is why we are working together very closely and presenting to you together today. So I'm just going to briefly talk about the integrated plans. And for those of you who aren't as familiar, and so the integrated plan is the new requirement under BHSA and serves as a 3-year spending plan for county behavioral health departments. And so this is the process that replaces the old community planning process. It has to describe how counties will use their BHSA funds across housing, full service partnerships, behavioral health services, and supports and prevention. It also includes data and outcomes to show how services are making a difference. It must demonstrate how equity, inclusion, and community engagement are being prioritized. And it must also reflect meaningful stakeholder input, which is where all of you come in. And the timelines for this includes like 3 big categories that they've identified. And so there's the draft development timeline, which is what we're in right now. And then there's a public review period. So once the draft is ready, it must be shared with the public for review and comment. And this is really critical opportunity for community members to weigh in. And then there's the final adoption of the plan. I know this is really fast, but we have a brief amount of time to kind of share this with you. So if you have questions after, I'm always available for that. Let's see, hold on. Okay, and here we just kind of are highlighting, why it's important. And so the integrated plan is going to be a roadmap for how the behavioral health services will be delivered in your community. And it determines what services are funded and who gets served. And that's why your voice is really important in this planning process, and why like Brenda and I are taking time to kind of to highlight this and share with individuals these opportunities. So on this slide, you can see the deadlines if you're not as familiar with them. And so typically what we're doing is we're encouraging people to attend. But here you can see that the draft are due March 31st, and the final integrated plans are due June 30th, 2026. And I think I did it. 5 minutes or less, right? So does anybody have any questions? Or I think we want to hear from Brenda
Yeah, I can go ahead
next.
and keep the momentum going and then we can open up
Yes.
for questions. So thank you
Thank
so
you.
much, Jenny. And so as the county, the planning council started in the 90s with that block grant. The commission came online at the turn of the century, around 2004 was when the Mental Health Services Act passed and established the commission in 2005. So we were originally the Mental Health Services Oversight and Accountability Commission, and with the change from MHSA, Mental Health Services Act, to Behavioral Health Services Act, we've now become the Behavioral Health Services Oversight and Accountability Commission, which is a very long name. So we've just kind of rebranded to Commission for Behavioral Health. So I'm Brenda Grealish. Is everyone able to hear me? I see in the chat that some folks might not be able to hear me. Can most of you guys hear me?
Yes.
Okay, all right. So maybe I don't know what might be happening there. So okay, thanks you guys. Great responses there. Okay, thank you. So I'm Brenda Grealish. I'm the executive director for the Commission for Behavioral Health. As Jenny mentioned, we kind of work very closely together. We've worked together for years, and so I've been in some different roles throughout my career, and in this role, I have the pleasure to continue working with Jenny in this new role as her planning council, my commission do differ, but very similar and somewhat sometimes overlapping kind of work. So we want to try to stay coordinated. Next slide, please. Really appreciate the opportunity to be here today. Just to even, I don't know, I was gonna say actually maybe by show of hands or those little thumbs up you guys were all doing. How many of you have heard of this commission before? Commission for Behavioral Health. Anybody? Oh, all right. Okay. I love the little burst thing. That's fun. Okay. Okay, cool. You guys have heard of us before. Fantastic. So with MHSA, we had 16 commissioners. The move to BHSA has moved us up to 27 commissioners. So we have a variety of really great perspectives of behavioral health consumers, family members, providers, educators. We got some criminal justice folks and some other business leaders. on our commission. So it's a great complement of expertise across the board to be able to bring to this space and really kind of think comprehensively about our behavioral health system in California. I will say, in terms of our what we're able to look at in the system. It was very broad in terms of we can advise the governor and the legislature on pretty much any aspect of the behavioral health system. We are funded by BHSA though 100%, and so of course with that funding comes the strings that come with each of those funding allocations, and so but it's really great because we have a chance to really do some work in this space with our different grant programs. If you want to head to the next slide, I could kind of go over with you in terms of kind of what's in our portfolio, really focusing on kind of continuous transformational changes. Our system continues to evolve. And so we at the Commission have data. So we have a whole research team that looks at data. We have data sharing agreements with a variety of entities where we're working on dashboards. We've got some dashboards that have been available for many years, and we're actually in the process right now of looking at those dashboards and looking to update those and evolve those with the BHSA. We also have a few funding allocations that we're able to provide grants and technical assistance and other kinds of support. So we have a Mental Health Wellness Act grants. We have our Behavioral Health Student Services and Supports Act grants. We've got grants for lived experience and advocacy to build out advocacy in the local communities. And then we have our Innovation Partnership Fund, which I will talk about in a moment. So really that other space, and we do, like I was mentioning, have those advocacy grants, and we really try to lift up the voices of individuals with lived experience, both here at the state level as well as in our communities. Next slide, please. Just a little bit about what we have SUD related in our portfolio. So under Mental Health Services Act, SUD was part of it, but only with a nexus for people who had co-occurring serious mental illness and substance use disorders. With the change to BHSA, as many of you might know, you could do SUD as a standalone. So we already had some projects kind of underway within our portfolio under using our Mental Health Wellness Act funds last year, about almost 2 years ago, started a MAT pilot program in Los Angeles, Marin, and Nevada counties, really looking to expand MAT in non-medical medical settings, trying to increase the number of MAT prescribers in the specialty SUD system, and doing some work in the billing space. Not glamorous, but important work to do because it's kind of where folks get tripped up. So we're able to, the way I kind of think of it is we're able to kind of petri dish some of this work, get some of the kinks worked out, and then make that information available to our counties and other folks to be able to make improvements in the system. So this project's slated to go through 2027, and so it's just a really exciting project that we have underway. We're also we've been working with our advocacy contractors that I was just talking about in terms of updating our advocacy contracts to focus on substance use disorder and really just the BHSA priority populations in general, because there wasn't a real focus on our kind of higher needs populations as the BHSA is envisioning. So we've been working with our advocacy contractors to be able to really focus in on some of those folks with the highest needs. And then we're looking at ways to integrate substance use disorder work in our Behavioral Health Student Services Act grants. So we're going to be talking about a potential pilot project at our December Program Advisory Committee meeting in a couple of weeks for a potential integrated pilot in schools. Next slide, please. I was just mentioning our Innovation Partnership Fund. This is an allocation that we'll start getting starting July 1, 2026. It's a maximum of $20 million per year for 5 years, so total investment $100 million to try innovative projects to really improve behavioral health care in our state. And these innovation projects used to be at the local level. The counties would do it with their MHSA allocation. With BHSA, that is now brought up to the state and here at the commission. So we just recently, a couple weeks ago, our commissioners approved a innovation partnership fund framework. And now we're going to take that framework, and at our program advisory committee meeting in a couple of weeks, we will be talking about how we're going to operationalize that framework into an RFP for grants, which we're targeting to put the RFP out in late January, early February. So really exciting new project on the horizon there. And then kind of what Jenny was talking about with that integrated planning process with BHSA, our team's working on a BHSA community planning process toolkit. This is going to be a toolkit from the integrated planning, community planning process stakeholder perspective. So for the participants that show up at that meeting, kind of helping folks to prepare for those meetings and know how to show up for those conversations. So we've had a couple listening sessions on that so far, and then we're looking to publish that toolkit in January 2026. Next slide. And just a couple QR codes to find out a little bit more in terms of how to register for these our commission meetings, including our committee meetings, where, like I said, we have our program advisory committee that's going to be meeting in a couple weeks. That's going to be talking about some of these grants, including the Innovation Partnership Fund. And then you can also sign up to get information about our meetings, our grant information when those are released, and just general announcements that we have. So appreciate it. I'm sorry if I went over a little bit more than 5 minutes, but try to just get a little chock full of information and a power punch there. So appreciate it.
Thank you so much, you both. And actually, we have time for questions. And so I do have one question here from Renee. Will there be funding for certified substance use counselors within FQHCs? And Renee, is that for the BHSA integrated plans on the county
Hey,
level?
Betty.
Or are you talking about the Innovation Partnership Fund?
The Innovations Partnership Fund.
So the IPF is going to be grants, and workforce could be part of some of those grants. We do have to coordinate with Department of Healthcare Access and Information on some of that. So I'd say just keep an eye out for that RFP. I want to invite you to come to the program advisory committee meeting that we're going to be having in a couple of weeks to kind of hear how that's being operationalized, because that's kind of a work in progress. That will be on, I'll tell you, December 15th from 10 to noon.
Thank you so much. We're an FQHC, and we provide really robust medication-assisted treatment, and our SUD support staff, including counselors, we just can't do the work that we do, the quality that we do without them. So just curious about that. And is it possible to go back and show that slide or put the links to those meetings for registration in the chat?
Absolutely. And so I'll keep this slide on. We have a few more minutes for a few more questions. I have a question from Patricia. Are there specific agencies or partners for behavioral SUD specific to perinatal patients? And Patricia, feel free to come off mute and also ask your question. Okay, if Patricia's not still there, and we
I
can.
say,
Mhm.
in terms of agencies and partners specific to perinatal, like for behavioral / SUD, I will say, and I don't know if it 100% relates to Patricia's question, we do have in our Mental Health Wellness Act portfolio of grants, we just started a maternal mental health, or maternal behavioral health, I should say, 0 to 5 project. So we have several grants out right now. And that is projects that just started on July 1, 2025. So just a few months ago.
Thank you. One question, is there funding for a mobile integrated health program that is focused on a post-overdose response model?
I don't know if maybe Joseph's question has to do with like an innovative type of project.
Yes.
Okay.
I'm sorry. I just thought I'm like, trying to do multitasking here. So I work for Anti and Fire, and we're starting a program that it's teaming a paramedic and a nurse practitioner. And our funding right now is through opioid settlement, but it's going to set to run out for our agency within the next 3 years. So our response model to abide by the opioid settlement fund is to respond post overdose, and we're going to be offering Suboxone in the field with a goal of linking individuals to treatment centers. And our main focus is going to be substance use disorder and behavioral health. The majority of the individuals we'll be responding on will be unhoused individuals. So I wanted to see if there's opportunities for either funding or partnership with your group.
Yeah, I'd say it sounds innovative-ish. So in terms of potentials for those grants, I'd say definitely I popped that program advisory committee link into the chat. That's going to be where we'll be talking about the nuts and bolts of the Innovation Partnership Fund. And then
Okay.
from that meeting, then our RFP outline will go to that January full commission meeting. And then we'll be looking for our commissioners to hopefully vote to, move that forward, and then we can get the RFPs out. And that's what we're looking for. I mean, ideally, as the executive director, I'd like to see a variety or a pretty robust portfolio of grants of different kinds of work, both on the mental health and SUD and co-occurring as well space, so that we're really trying to kind of tackle the needs of this high needs population. So again, and I'll pop the framework into the chat as well, so you guys can see kind of how the IPF is being envisioned right now. So I'll try to do that real quick so that you guys can kind of at least get a gist of what it is and how we're defining innovation and kind of what the values are of so that you can start kind of familiarizing yourself with what what the commission is looking to see in the grant applications.
Okay, thank you very much.
In terms of the our meetings, they're always hybrid. So we have a virtual as well as in person. And honestly, for the committee meetings, because our commissioners are also allowed to be a virtual, pretty much we're the only ones in the room. The team, we have to be there for Bagley Keene. We have to be there in person. So people are always welcome, and we always love having folks come. But if it's more convenient to attend virtually, just would love to have you.
Do you have to register for the December 15th? Because when I clicked on that, when I did the QR code for the committee meetings, the first one it takes you to is a January 15th meeting. It doesn't show that December 15th one.
One might be coming up on the commission meetings versus the committee meetings. So yeah.
Okay.
Yeah.
Great. And I think we have time for one more question, but I don't see anything in the chat. So I will go ahead and close out our session. Brenda and Jenny, thank you so much for joining us. It was such an honor to have you both speak and also to talk about, what SUD integration looks like on a local and state level. I'm really, really happy to have you both here. There are people in the room that I've known from, in-person sessions too that let me know that they've attended their local BHSA or their county's BHSA meetings. And so that, learning more, if you have any questions, to go to Jenny, and also any like that toolkit is coming out. That's really exciting. But overall, just these updates were really helpful, and really happy and thankful that you came and made the time to come out here and speak to us today. So thank you both so much. And if you're available to stay, maybe some folks would be able to ask you questions directly, but we'll go ahead and continue with the rest of our session today.
Thank you.
Thank you
Thank
so
you.
much, you
Thank
guys.
you,
Really
Jenny.
appreciate
Thank
it. And appreciate all the work everyone is doing out there. It's very important work. So thank you.
Yes, thank you.
Thank you. And so now the most exciting part of our meeting today is our breakout session. So what do we want to do? We want to break down silos and get people talking, right? It's all about coordination. And Before we get into the breakout sessions, I want you to know it's okay. If you don't have audio and visual options, you can always participate in the chat function. You can always listen to one another. But you will have, your group discussions with the SUD experts in the room, which is you. And so you're going to have a facilitator out there, and we have something really exciting with you all today, and we're going to do a case study activity. If you've been to the past 3 virtual collaboratives, we've asked questions, but this time's a little bit different. We're going to walk through a case with Mariah, and we're going to ask you 3 questions. So while we're here together, I'm going to go ahead and read this and then go into the questions, and then we'll get into our breakout groups. But really, what I want you all to think about when you're thinking about the story and when we're reading through it together is really think about what does this look like for your county? Think about the players involved. Think about and what we were talking about with the state, that what type of support do you need from the state? What support do you need from your county? To help this particular individual, right? Think of big. How about the emergency rooms? What coordination needs to happen with the community providers? And so let's go ahead and read this together. And while you have those questions in your head, just keep that in mind as we read through this. So Mariah is a 35-year-old woman who has been unhoused for the past year and is currently living in her car with her partner. She reports polysubstance use and last used 8 hours ago. Her primary substance is fentanyl, which she uses daily, and she also drinks alcohol occasionally to help take the edge off her anxiety. She is now experiencing early withdrawal symptoms. Mariah shares that she has struggled with untreated anxiety for years and has never been consistently connected to mental health care. She has tried to seek SUD treatment several times in the past, but feels discouraged, expressing that nothing has ever really worked, and that she often leaves programs before completing them. She has never taken MAT and is unsure whether it will help her. Mariah has chronic pain, no insurance, and frequently misses appointments due to transportation challenges. She's primarily seeking relief from her acute withdrawal symptoms. There are 3 questions we want to ask about the case study today, which is where can Mariah go to get OUD treatment today? What resources are available for Mariah in your county? And be specific, give information about the name of the organization, their hours, etc. And how would Mariah know about the resources that are available to her? Is it going to be through one of these meetings? Is it going to be at a regional collaborative, right? How would Mariah know about these resources? Is it through a substance use navigator? We're going to go ahead and brainstorm all of that together in our breakout session. And we're going to do it by region. I did mention this. You're going to have an opportunity to be broken up. And so we'll have 5 groups today. It'll be Central Coast and Central Valley, Northern Rural and Sacramento, the Bay Area, and then SoCal will be also split up. So the Inland Empire, OC, Imperial and San Diego, and Los Angeles, Ventura. So we'll go ahead and get into our breakouts. And so you'll be automatically split into your groups. And then if you're not in the right room, that's totally okay. Just make sure that you leave that breakout room, go back to the main session, and Aiden, our training coordinator, will go ahead and help make sure that you're in the right room. And so again, Aiden is here to help you if there's something going on, like you need a little bit of support with the tech side, feel free to stay into the main room until you are assigned. And so we'll go ahead and go into our breakouts. A facilitator will meet you once you're there, and we'll go ahead and split up. And again, think about this all in the bigger picture. What we just learned from Jenny and Brenda, what support you need from organizations like them, groups like them, and also what support do you need from CE Bridge. Think about all of this holistically, and we'll go ahead and come back in about 25 minutes, and I will see you all there. Okay, great. Hi, everyone. Welcome back. We're all coming into the group together. I'm going to go ahead and share my screen again. Wait 1 second if I can get that all settled. Oops. Oh, that's not it. There you are. Okay, so let's do a recap together. Does someone from any one of the groups want to come off mute and talk about how you and your experience with Mariah? How did you help Mariah today? And I can call on, I know I had 5 different groups. I had great facilitators, great folks. Feel free to just raise your hand, come off mute. Let me know what it looks like for you. How did Mariah get help in your region today?
I'm gonna
Well, I
volunteer Roger to share the really, really wonderful ways that he would help. I forgot her name already.
You forgot my name's Roger.
Not you, the
The other Cal Bridge worker that was here. Yeah, we're bad. Okay, so they first said you can't go to the ER. Well, I'm sorry, I work in the ER. So the first place she came was to the ER. So she was detoxing, so I got her started on Suboxone and got her stabilized on Suboxone, and then I referred her to either Aegis or Medmark, depending if they were open or not, and they'd be seen today or tomorrow, the next day. So I make sure she have enough dosage to get her through to there. And if she's going to another program, such as our CMC respite or CMC outpatient treatment, I would make sure she had an appointment before she left the office, and I would make sure she had enough Suboxone to get her through to that appointment. And I wouldn't just treat the excuse me, I would make suggestions to the doctor to give her some anxiety medication, some Zofran, and everything to help her with, the withdrawal symptoms, as well as what's going on with her life with the anxiety and so forth. If she wanted to get into residential treatment, which she didn't like, I couldn't do quickly, but I can get her in within a couple of days, especially if she's admitted into the hospital. She had different options for that. Being a woman, I can get her in a place called Family Ties here in Stockton. I could get her into the CMC Respite, which is here in Stockton. Usually takes a few days, providing if she's admitted in the hospital. If she wasn't in the hospital, I make sure she had an appointment to follow up care with that, which it sounds like she really doesn't want to get into treatment again. She's been through it. So I would just make sure she got referred to a clinic and make sure she has enough Suboxone, get her through there, make sure all her healthcare needs are taken care of. Give her some bus passes, but she has a car. Sounds like that's what I would do for her here. And I did it for somebody yesterday.
Yeah, thank you so much, Roger. And even in my group as well, a lot of them had shared and raised their hand. I said, who here has, encountered a patient very similar to Mariah's story, right? To what Mariah is experiencing. And a lot of them had raised their hands and said, yes, we have seen patients like this. And a lot of you have, especially the navigators in the room, worked with people like Mariah every single day. And it does require coordination of services. It does require like a sharing of resources as well and coordinated care. And this is why we wanted to bring you all together today. It was really awesome at the end of our group. Everyone was able to share their information with one another and say like, hey, I want to learn more about what you're doing. I want to be connected to you. I want to, I just want to connect. And so this is exactly what we wanted to do in our breakout sessions today. Although this is the last Regional Collab of the year, we hope to bring more of these opportunities with you all in the upcoming year. And I am going to continue on to the next session as we come to a close. If there's any, yes, and we need to keep funding our sons in a big way. Julie, you're so right? They are so integral to the work that we're doing. Everyone in the room, you all do such important work, and we really need to uplift the work that navigators are doing. So again, thank you so much, Roger, for sharing. And we have more opportunities, hopefully next year, to continue gathering and talk. And so I have the honor of introducing our next speaker. It's one of our own to talk about rapid mat expansion, Dr. Andrew Herring, a founder and also principal investigator with Cedar Bridge, will be talking to us today about rapid med expansion and what this can look like for you all.
Awesome. Thanks. Thank you. So happy to be here. Maybe just move into the slides, please. Um, so I'm an emergency physician first, and I then became an addiction physician and work with all these wonderful people at Bridge to try to come up with ways to make the health system really work for people who are struggling with substance use disorders, particularly opioids. The the big thing that we've seen, I think if there's one mindset change that really needs to happen for the entire system from the top down to the bottom is this idea. Let me just go back to that previous slide. Is this idea that substance use disorders, particularly opioid use disorder, is a crisis. Um, and what that means to say is that giving someone a piece of paper and saying, good luck, call it when you're ready, which was established as the standard of care, like that was acceptable care. Or, hey, here's a volunteer group, Alcoholics Anonymous, or some another 12-step type group that you might look up, where it's really thought of as something that you do in your own time when you're ready. What the opioid epidemic taught us is that's just not right, is that people die on a day-to-day, week-to-week, month-to-month basis. And when they're ready, you gotta be there and use effective evidence-based treatments, or there's a chance that they're gonna actually die. And that core understanding is what's missing in medicine and behavioral health. And that's the big thing that we're trying to change is that using fentanyl in particular is a crisis. And we know what a crisis system looks like. And this is the three essential components of one. You have to have someone to call. You got to be available. Someone's got to be there, ready to respond, and that's a navigator, right? That's you all, who is non-judgmental, knowledgeable about hyper-local, pragmatic, real resources that work in an immediate time frame, and you need a safe place to go, where you're actually physically can be cared for, and that's the emergency department. Next slide. This was our big play. We kind of went in reverse order. We started with the ER, and it worked, right? A lot of people told us that it wasn't the right thing to do, that it wouldn't work. It did, and, navigators want to help people in the ER. Lots of docs and APPs and nurses, people want to do the right thing and help. So we got this off the ground in almost every hospital in California. We showed that you can really do this. Then the question is, do you actually have to physically go to the ER? Next slide. And if you do offer it, are people going to accept it? And this again, that idea of readiness and all those ways that honestly kind of out of date programs explained why they were so small and reaching so many people, explained why they didn't need to change while the overdose rates doubled and tripled and quadrupled. Um, what we found is that when a knowledgeable, pragmatic, compassionate, non-judgmental, cool person just approaches you in the ER when you're obviously showing signs of struggling with an opioid, almost everyone wanted help. This is not rocket science. You offer it in a reasonable way and people accept it. So we did the research and we found 85% of people living with opioid use disorder wanted to get started. So, next slide. So, this slide is a fun graphic, but basically it says a lot of things. It says some hopeful things and some challenging things. It says that actually, in the grand scheme of things, opening up the ER to just tons of people, like no barrier, no enrollment, just come in and get started. That actually a lot of people, they call this idea of number needed to treat. So it's like 1 in 9 people, once you start them on buprenorphine, stick and they stick like really solidly, like they have 6 months of a continuous prescription. That seems small, but in the course of medicine, if I'm in the ER and I start someone on blood pressure medicine, I start on something for their cholesterol, I start them on, anything else, the numbers are really small. So that number needed to treat of 9 or 10 is one of the most effective things that we could do in the ER. So that should be this huge inspiration of all of that idea that no, it doesn't work unless you have these elaborate, complex programs um, that's just not true. What you need to do is get to people and offer them evidence-based treatment. What it also shows is that getting there is complicated with a lot of stumbles. This is not a one-time event. And this is where navigation comes in. Like once you get started, you're going to need a partner, a collaborator that's with you, available as much as possible for the long haul, because you're going to have slip ups, right? You're going to fall off and then need to get restarted as quickly as possible. And so that churn of work, this middle ground of people who fell out, that's where all of our resources need to go to shortening up that cycle. You stumble and you need to get back on board as quickly as possible with as least drama as possible and just go back in to get as more people stuck into long-term care. Next slide. So this is the idea. This is a crisis. It's real. It's real time. It can't be in a day. It can't be in a week. It needs to be real time. Next slide. So this is the question that I ask, in all of my talks, is like right now, I'm sure, right, many of you, if you have a friend, a family member, do you know where you would send them today, right? If they asked you for help, if your friend from college or high school or work said, hey, I'm actually buying Oxy online from some random guy I met after I blew out my knee 3 years ago. I'm in trouble and I want to stop. Where do they go? Without having to quit their job, without having to go into residential, without having to do all these things. Like, where could you send them today? Next slide. With this idea that if they're using, they need help right away, immediately, right? And so this is this plan that most communities don't have. And probably most of you on this call, you might have your own personal number, but there's a lot of you probably don't know where you'd go. Maybe you would go to the ER, or maybe someplace that could get you in the next week, but you probably don't know someone who could get in touch with them right away, right? And if you do, you're probably unique, and people coming into your community probably don't know how to find you. It's all like hidden. Next slide. So we're trying to shatter this idea that county access lines can accept this idea of referral as being an appropriate response. Next slide. And elevate the role of hyperlocal navigators who are connected to the real-time heroes, because they're out there. Every time we do these collaboratives, we find these new people we didn't know existed that are offering same-day walk-in evidence-based treatment to anyone, regardless of insurance status. But they're hidden out. And so we're finding navigators that have found these folks and cultivated these relationships. And we want to bring them together into one team that spans the entire state of California so that every single person knows how to get in touch with this hive mind that can get them into care same day. Next slide. And so that's the vision of Bridge Connect. It's like the idea of 988, where you've got 400 navigators connected to 1,000 clinics, or who knows how many, right? 100 clinics, 100 ERs, with a single entry point, either on the phone or on the text or on the web. This is what we do for suicidality with 988. This is what we do for people with tobacco with Kick It California. The model's proven, just no one's done it for opioid use disorder. So this is what we're investing in that sits on top of all the amazing work you're doing and becomes this funnel that brings people that are ready and interested in treatment into contact with you so you can leverage that, or you can shepherd and navigate that person into local services that are effective and tying together this fragmented, siloed system. That's our big vision and our passion right now. Next slide. So this is how it would look. So you've got real-time crisis care for opioid addiction that's combined with the physical 24/7 ED as this fallback. And so basically, a lot of ways, the cell phone is the modern ER, right? And almost everyone's got one or can get one. And so if you've got a phone, you can get in touch with someone who can prescribe uh, buprenorphine or get you into a methadone clinic, right? There are pharmacies that can give long-acting injectables with the prescriptions. Like, the power of the phone is transformational, right? When we just got to actually leverage and create that opportunity with a publicly available number and access point that people can know. It becomes the tip of the tongue. Every bus driver, every subway person, every librarian, every policeman, every fireman, every ER doc should all know that there's a simple way to get people into treatment connected with the navigation team. It's an actualizable dream that is relatively inexpensive for the amount of how many people it could reach. You engage them, get them hooked up with the navigator, and then into local treatment, and then stay in touch to make sure you're doing okay with little nudges, check-ins, that kind of thing. And that's the system we're going to build with Bridge Connect. Next slide. So the question, right, is your community prepared, right? Have you really thought, do you have a comprehensive system for someone using fentanyl, for anyone getting off the bus in your community, so that they have a single number that they can call, a single place that they can log into, they get connected to a navigator for same-day help? Like, that's the challenge we're putting out to every county in California. Next slide. Great. So thank you. I just am so in awe of all the work that happens on the ground, so much that I don't know, all those hidden heroes. And again, please reach out if you're one of those people that's offering real-time, same-day buprenorphine to anyone, regardless of their insurance status. We want to know who you are, because you are a hero. You should be famous, right? And we want to make you at the center of the California approach to the opioid epidemic. So please, please, please be in touch, and thank you for your time.
Thank you so much, Dr. Herring. And then we actually, I think we have a question for you before you, yeah,
Yes.
is there any funding required to bring, oh, it kind of disappeared, to bring California Bridge's innovative emergency medicine models to hospitals?
Well, yeah, uh, money is the language of medicine, right? If you want something to happen, you got to pay for it. And so we're just beating down doors, kicking shins, yelling, screaming, and doing everything we can to get the state of California, to get private donors to care and pay attention to this, and dedicate resources to the number one cause of death in adults under 55. Like, this is a no-brainer. But there's a lot of stigma out there at the top. I see it more at the top than I see it anywhere else, and so we're fighting that. We're really focused on driving this idea of a universal access point with Bridge Connect, because we think what it'll do is it'll create these obvious demand that's going to push hospitals and push clinics to change and use existing funding systems to take care of folks. Because right now what they're doing is they're really trying to tell people that people don't want treatment. And so we're trying to prove the opposite. And to do that, we need to recruit them into the system, get them to call, get them engaged, and that's how we're going to push this wheel of development. That's our strategy. So
Thank you. Thank you so much, Dr. Herring. That is all the questions we have for you. And we'll move on to our next session. But before that, I just want to say thank you so much for sharing where we're headed with California Bridge, what we're bringing. In our breakout group, we were really talking about like how do we break down these silos? We have all these different services. How do we stay connected? And really bringing it to having one access point would be really, really innovative. And that's something that we're hoping to bring and a model, and that it's going to require everyone to be a part of. So thank you everyone who's in this call today, and thank you for being a part of what we're doing and being a part of the momentum and movement. And so to close us out, in the next 5 minutes, we have a navigator story, and I have the awesome opportunity to introduce Katie Quijada, one of our own, our new Sea Bridge Connect navigator. And Katie is the navigator behind the Sea Bridge Connect service that Dr. Herring just talked about. And she joined Sea Bridge with 7 years of frontline experience working with people who use drugs in harm reduction programs, street medicine outreach, and emergency departments across California. Katie was drawn to California Bridge because their mission and ethos are congruent with their passion for harm reduction, sexual and reproductive health, LGBTQ plus health, and dismantling systemic barriers for marginalized populations. And I will go ahead and give it to you, Katie. Take it away.
Thank you so much, Cheryl. And yeah, so to introduce myself, I'm Katie. I am the California Bridge Connect Navigator. So I will be the voice behind, I'll be the person who picks up the phone when this service gets launched. So I look forward to meeting all of the different navigators across California. I know there's a ton of you. Super, super excited to be a part of this project. The story that I want to share is from when I was a substance use navigator at UC Irvine Medical Center. It isn't set in an emergency department, actually. My Monday morning started with multiple missed calls from the pain management team asking me to go see a patient in the ICU. She had been in a really horrible pedestrian car accident, resulting in some pretty bad leg injuries. And they wanted me to go and see her to see if she would be appropriate to start on methadone. Because of her pain and her pain management needs, she wasn't able to start on buprenorphine right away, but she was having really severe opioid withdrawal. To describe her a little bit, she's female in her 50s, homeless, and she has been using heroin and then eventually fentanyl since the 80s. So she has decades and decades of opioid use under her belt. And this accident happened. She was pinned between two cars, and she was going to be staying in our hospital for a good long while. So we wanted to treat and address the opioid withdrawal while we worked on everything else. So some complications and barriers for this patient include that she's homeless, she has no ID, she has no phone, and she's never been to a methadone clinic before, so she has no enrollment history anywhere with any clinic nearby. Also, she's going to be in a wheelchair when she discharges. So, what was tasked to me was to say, okay, can I find a clinic that will accept this patient with no ID, no contact, in a wheelchair, uh, and has never been anywhere before? Uh, Thankfully, she had some really good strengths to support her as well. She had really strong family support through her partner and her son. She was enrolled in Medi-Cal already, so she had insurance, and she was super motivated to stop using fentanyl and to continue her methadone treatments once she started. She kind of considered this accident like a life-changing moment for her, where she realized, oh my gosh, I almost died. Let me make changes. I want to support myself the best I can. Um, so finding a methadone clinic that would accept a patient with all of these barriers and all of these issues was pretty difficult. And it really highlights the need for substance use navigators to be able to know what resources are available in your area, and know exactly what a patient needs to do to get in and stay with them. So what I had to do is I had to call the clinic manager at the methadone clinic and say, hey, I have this patient and these are all the issues going on with her. Can you take her anyway? And the workaround that we figured was that I could send them through fax a patient face sheet and a photo of her in lieu of ID. So even though she didn't have an ID, I could send that information to the methadone clinic and they would be ready to accept her when she could come in. So Not only that, I had to make sure that the methadone clinic wasn't on a second story because we did have another clinic that was, and I couldn't refer her to. So all of this stuff had to happen. All of this coordination had to happen before she would discharge. And our patients face barriers that they struggle to overcome on their own. I don't think this patient could have gotten to this methadone clinic without my help, point blank. I don't think that she would have been able to discharge and start up at a methadone clinic without me facilitating that, which again is just highlighting the substance use navigators that we have here in this call and the ones that we have across California. Knowing what we know is the reason that our patients are able to get the care that they need. Yeah, thank you.
Thank you so much, Kate, for sharing that story. Again, it really highlights how a lot of our patients face so many barriers to get connected to treatment. And it really puts the substance use navigators in the center of all. You help make it happen, and all of the partnerships that you make, and the relationships that you make with all of the community resources, with the emergency department clinicians, etc. You all make it happen. So again, once again highlighting the great work that navigators do, but also the integral role that everyone has to play in helping an individual to getting and staying in treatment. And so that is it for the Virtual Regional Collaborative. We're going to close out with some announcements. Jenny and Brenda really shared some great, priorities with what's happening at the Commission for Behavioral Health and also what's happening locally with the BHSA integrated plans. And if you're interested, for those of you who have been attending those meetings or who are interested in attending those meetings and want some more information on how do we show up, how do we tell them and share what we want as priorities for this funding or these different opportunities, we provide technical assistance and we're really great at that and we can help support you. I know they're coming out with a toolkit, but we are also here to support you in that process. And so on our webpage, you'll find a link to our, request technical assistance, and you can be connected to someone who can help support you with whatever advocacy you want to do, whether it's going to your BHSA county local meetings or going to the Commission for Behavioral Health Commission meetings as well. And really great to see some of your faces in those meetings, and really discuss where we want where we want things to be a priority. Next slide, we have our 2026 Regional Collaborative. So stay tuned. This is our last Regional Collaborative event of the year, our last virtual event of the year, and then just overall, it's just been a great pleasure to really host these and to bring everyone into the room. Thank you so much for being a part of, what we're building, this Rapid MAT network. And also thank you so much for your role in expanding access to low barrier MAT this year. You all do such important work, and it requires all of us to make this happen. And so thank you so much. We will be bringing back the virtual and in-person regional collaboratives, and it'll resume in 2026. More information will be available, but subscribe to our Bridge newsletter for more updates. Again, you'll have access to these slides, so you'll be able to click through these links once you get them. For those of you who need CEUs, here is our evaluation link. Thank you for staying through all the way to the end. Today's event is eligible for 1.5 CEUs for my CHWs in the room and also my substance use counselors and peer support specialists. And this will be available until December 10, 2025. And so for my CHWs and substance use counselors, use the QR code on the left. And then for my peer support specialists, use the QR code on the right. And so I'm going to go actually close this out, and then I'll bring it back to the evaluation slide in a bit. But thank you so much again for attending. Enjoy the rest of your day. Change will not come if we wait for some other person or some time. We are the ones we've been waiting for. We are the change that we seek. This quote is from Barack Obama. Thank you so much, and happy holidays, everyone.